Thank you, Jim. I don't know if you noticed when I came up here, I looked shocked. I was, because they had sent me an email telling me I was going to go earlier, and then I looked at all the schedule, and I go, oh, no, I'm at 1 o'clock, so I'm sitting back there. I got lots of time, and I think I'm going to eat my donut, and well, that's all gone. So we'll get started here. All right. So I get the pleasure of talking about hematologic malignancy, something near and dear to my heart. It's why I went into oncology. The first patient I took care of as an intern, first rotation, was on a leukemia service, and I was, as no pun intended, undifferentiated at that time, but I knew that that's what I want to do. And so it was a very exciting ASCO. And matter of fact, so I always think about when ASCO, if I don't get to go or there's so many sessions, I go, I just want to know the bottom line. So what you're going to see today is I'm going to highlight in a number of diseases some of the really great abstracts that actually, I think, are applicable to clinical practice. And I just want to acknowledge, this is what's so great about our field. So I chose like 20 abstracts, and I know I have 30 minutes. And I wrote every single author who presented an oral abstract, and I said, can I have your slides? I would get some of them within 5 minutes. It's a really great thing about our community. So I just want to say that. So what you're seeing, the slides you're going to see, if they've only been slightly modified just because I tend to be anal retentive in my PowerPoint presentations, but they're pretty much the same thing. So let's first start with multiple myeloma. So in the community, when we see a patient with multiple myeloma, we make a designation whether or not they're transplant eligible or transplant ineligible. And I get very defensive about this because I think almost every patient is transplant eligible, but they're not always. But the French and the Europeans seem to define it as anybody over the age of 65. So I am transplant ineligible as of this year. And that's my first bad joke, and so, okay. And so, but they also, so there were two major trials presented. So the first was isatuximab plus lenalidomide and dex with weekly bortezomib versus ixatuximab and lenalidomide and dexamethasone. And why this is important in transplant ineligible, this is considered a standard of care, is isatuximab rev dex. And they actually wanted to say, well, based upon quadruplet data, could they add bortezomib to the regimen? And I will just distinguish that when they added bortezomib, it's a day 1, 8, and 15 administration, instead of a twice weekly. And that has a lot to do with your elderly patients, in terms of neuropathy like symptoms. And in this study, the primary endpoint is achieving a MRD negative remission. And so MRD correlates with progression-free survival and overall survival. And now that we have clonoSEQ, it's actually been approved. Now it's for your clinical practice. MRD has become the gold standard for what we achieve. And what they were able to demonstrate from this trial is that you can see that the addition of bortezomib in terms of achieving a 10 to the minus fifth and 10 to the minus fifth was superior with the addition of Velcade to standard isatuximab plus RevDex. And when we look at at 18 months, and again at 10 to the minus fifth and 10 to the minus sixth, and again, you can see here clearly, and this is a primary endpoint of at least achieving 10 to the minus fifth, that these patients had improved MRD. And matter of fact, the conclusion to this abstract is that isatuximab plus Rev plus Dex plus weekly bortezomib is a new standard of care in transplant ineligible patients. Now, simultaneously, back to back, the French, who love myeloma apparently, just like they do with colon cancer, reported another study because the other standard of care regimen in transplant ineligible patients is VRD. But with this VRD that they give to patients, that is twice weekly. So days 1, 4, 8, and 11. And they actually wanted to look, and you can look at this kind of an interesting way. They wanted to know if you added isatuximab, which is I failed to mention, a CD38 monoclonal antibody. If you add it to this regimen, would you get improved outcomes? And in this study, the primary endpoint was progression-free survival. So here is the overall response rates. And if we look here, we can see that it's almost nearly identical, that you have 90%. And that's the beautiful thing about myeloma, is we can turn to our patients and we have a high degree of response rates. But if you look at that in terms of when you add isatuximab, you have a significant increase in the patients who achieve a complete remission, including a 10% stringent complete response rate. And then again, if we look at this MRD rating, and this is looking at in an intent to treat model, that you get 60% of patients achieve MRD, and this is 10 to the minus fifth. And that if you look among the complete responders, it's at 55%. And if you look if it's sustained at 12 months, it's 47% versus 24% through the addition of isatuximab to standard VRD. And then if we look at the primary endpoint, and I really want to emphasize this, is look at the progression-free survival. And this is at 60 months, and it hasn't even been reached yet. And the standard VRD arm, it's 48%. But the thing that this is such a remarkable, because I can for Jim and Phil and I, when I was first into this, I used to turn to every single patient. I go, your median overall survival is 3 years. And yet this is in a transplant ineligible group, and yet we're looking at 60 months, and they haven't even reached the median progression-free survival, and that actually correlates with overall survival. And this is the first study in transplant-ineligible patients where you're seeing these types of results. So I really do think it's adaptable to clinical practice. Now, in the transplant-eligible population, we actually saw another monoclonal antibody investigated, and this is daratumumab. This is also a CD38 monoclonal antibody, and they actually looked at this in terms of the addition to VRD. Patients would go on to get a transplant, and then they had maintenance therapy with Revlimid and daratumumab post-transplant. And in this study, again, they wanted to look, this had been previously published in the New England Journal of Medicine, but they wanted to look again at MRD. And so just to show you the significant results in regard to this is progression-free survival. And again, look at the numbers here. We are up here, and again, at 4 years, with about an 85% progression-free survival through the addition of daratumumab to VRD in the transplant setting. And again, if we look at MRD negativity rates, overall, with the addition of daratumumab to VRD, we're up at 75% achieving MRD negativity, and this can be, and it can be sustained beyond 12 months at 65%. So we're seeing really, really remarkable results in that regard. And then if we look at it, what the addition of daratumumab in terms of the maintenance therapy, we see that it continues to increase over time, that there's almost a doubling of MRD negativity when you get out to 48 months to the addition of daratumumab. So the conclusion from this is that quadruplet therapy in transplant-eligible patients with transplant has become the new standard of care. So you saw 2 new standards of care that were demonstrated in multiple myeloma. Now, one of the more interesting papers was presented by the Joint Mayo Group. So they say it is a single institution, which is really interesting because it includes Jacksonville, it includes Scottsdale, and it includes Rochester. But the question that's come up among people who treat multiple myeloma is the sequencing, because now we have antibodies, we have bispecific antibodies, we have CAR T cells, and we actually have antibody drug conjugates. And they did a really neat thing, is they looked at 340 patients approximately, and whether or not they got CARs, or they got a bispecific, or they got an antibody drug conjugate. And they wanted to see what the outcomes were among these patients and whether sequencing made a difference. Now, 300 of the patients only got one of the 3 therapies, and the other 40 patients got either 2 of the treatments, and even there was a tiny group that got all 3 patients, all 3 groups. But I did want to show, relative to this, is that when you look at the efficacy, because there's an argument about this, and that CAR T-cell, median overall survival for patients who receive CAR T-cells was 33.4 months versus 18 months versus 5.6 months for T-cell engagers and antibody-drug conjugates. If you look at median progression-free survival, it's 13.4 months, 4.6 months, and 1.9 months, which are shown by these Kaplan-Meier curves. The other important thing is that if you had a prior BCMA therapy, it lowered the chances for that success in a second-line setting for each specific modality. However, the greatest impact, if you're going to decrease it, is the decrease upon efficacy of CAR T-cell therapy, that it dropped at about 50% if they got a prior BCMA with either an ADC or with a T-cell engager. So this is provocative data, but I would argue that we do need to be carefully think about how we're sequencing, and that this data really clearly shows that if you have a patient who you're thinking about BCMA therapy, I would suggest that CAR T-cell therapy may be the best way to go. Let's switch to chronic myeloid leukemia. And again, this is the most common myeloid malignancy. Every single practice out there sees chronic myeloid leukemia. And there were 2 cool abstracts that were presented at ASCO in regard to this. So the first was the ACS4 first trial. And this is investigating a novel tyrosine kinase inhibitor known as asacitinib. And what they did, I'm going to show, I tried not to show trial design, but I think it's really important for this abstract. So any patient could receive this. They were newly diagnosed chronic myeloid leukemia. And what they first did, they were going to be randomized to asacitinib or investigator choice. But the investigator had to decide if they were going to use standard of care, whether they're going to use imatinib, which is the oldest TKI we have, or one of the second generation TKIs. And then they were stratified, all patients, based upon which choice and their risk factors into these 2 arms. And so what it was shown, and again, this is looking at a major molecular response, which is the gold standard now we have for chronic myeloid leukemia. And when we look at this, we can see that for asacitinib, it beat all comers at 67% versus 49%. And if we look further at looking at trying to achieve a high degree of molecular response, that it continued to hold at the lower levels, and so that we actually got down to MR4-5, again, about a doubling. And so this was superior, and it held in both arms. It was most superior to imatinib, but it was also superior in second-generation TKIs. And so actually, the conclusion by Dr. Cortez, who was the senior author on this, is that patatinib has become the new gold standard for the treatment of patients with chronic myeloid leukemia. So another one is for those who are not familiar with chronic myeloid leukemia, there is a mutation referred to as T315I. And this is actually seen in about 25% of chronic myeloid leukemia, and patients tend to be relatively refractory to standard tyrosine kinase inhibitors. And ponatinib is a second or third generation TKI, which actually can overcome T315I, as well as other mutations that have been observed in chronic myeloid leukemia. And so the OPTIC study actually studied newly diagnosed patients who had T315I or had received 2 or more prior other TKIs, and to see how they would respond to this drug. And so they looked actually at 3 dose levels, 45, 30, and 15, and then if they achieved a molecular response, they actually reduced the dose down to 15. So this was the result. So when they looked at patients who had this T315I, you can see that a major molecular response was achieved in 64% of patients. And it's actually very similar to those patients who had no mutations. Remember, if you had 2 or more TKIs, you could be on this. When you look at with other mutations, it still could overcome, it didn't reach statistical significance. What they demonstrated was that the superior dose in this situation was the 45 milligram dose, and that by going down to 15, you got the greatest efficacy and had acceptable toxicity, and that was our recommended dose. So I think this is a new standard that we have for those patients with T135I mutations. And again, just this shows the overall safety results for the 3, and you can see that this generally is associated with very poor prognosis, and yet we see that these curves do not reach statistical significance. Here's what we see without mutation. So even if you've had prior to TKIs, and then the numbers are too small, but essentially there's no difference in those patients who have mutations outside of T315. So now I'm going to turn to lymphoma, near and dear to my heart. This was a study presented by Tycel Phillips, and it's glofitamab. For those who are not familiar with glofitamab is a bispecific, and it's a set duration bispecific. It's been approved in the use of diffuse large B-cell lymphoma. What's unique about this is they actually give another CD20 monoclonal antibody beforehand, because glofitamab is a CD20 targeted bispecific, but they actually give obinutuzumab beforehand. And the idea behind that is if you deplete normal B cells ahead of time, it actually will cut down on cytokine release syndrome, which can be a toxicity observed with that. So they actually looked in this study, they treated mantle cell lymphoma, which is a difficult disease that once it's relapsed, and they looked at 2 different doses of obinutuzumab. And so these are updated studies. And I think it's really quite impressive, because if you look at Bruton tyrosine kinase inhibitors are a standard second-line therapy, and now have been incorporated in first-line therapy. So they looked at patients who had had prior Bruton tyrosine kinase inhibitors. The overall response rate was 74%, but the overwhelming majority of these were complete remissions. And if they look at the BTKI naive patients, you can see nearly 100% response rate and over 85% complete remissions. And again, remember, these are relapsed refractory patients. And then looking, you see for the overall patient populations. But what's interesting is that now progression-free survival for within the BTK is 8.6. For all patients, it's 16.8 months. But again, we see a plateau. And again, what we would think that the median progression-free survival for other things would be about 6 months. So this actually is an improvement. And when we look at overall survival here, it just barely reaches coming out here at nearly 2.5 years. So actually, I think glofitamab does benefit a significant proportion of patients and is an excellent option for those patients, particularly after going 2 or more lines of therapy for relapse mantle cell lymphoma. Now, another thing that was looked at was again a report. This is actually a 26 or 25 institution cohort study. And this looked at the benefit of rituximab maintenance after standard induction therapy with bendamustine and rituximab. Now, just as a background, rituximab has been demonstrated to improve progression-free survival and overall survival in patients who get R-CHOP for induction chemotherapy. But it's been clearly demonstrated that bendamustine and rituximab is superior to R-CHOP in newly diagnosed multiple or mantle cell lymphoma patients. Now, there was a study in Europe called the MAINTAIN study that actually looked at, it was a well-designed randomized study that looked at giving maintenance therapy after bendamustine, rituximab, and showed no improvement in progression-free survival, no improvement in overall survival. And yet, there was a lot, other people said, well, there's other retrospective data that actually shows that that it can be beneficial. So what this group did, they did an observational study. They looked at 796 patients who did between, 2007 and 2020, who did receive bendamustine rituximab as standard induction therapy. And what they did was they eliminated 183. They did an analysis where they had to have achieved a CR or a PR and held it for 3 months. And then the investigators were allowed to choose whatever they want to do, either give maintenance based on their own feeling or not give maintenance based upon the maintained data. And it just is very interesting to me that it actually almost came perfectly balanced, 48 versus 52%, versus did not receive and did receive maintenance therapy. And what this demonstrated was an improvement in event-free survival and overall survival by the addition of maintenance therapy. So I think we should again rethink if the role of maintenance rituximab after induction with bendamustine and rituximab in frontline therapy for newly diagnosed mantle cell lymphoma. So venetoclax, I think I was out at the coffee thing, and they're actually having venetoclax that you can add to your coffee, because we're adding it to almost every other single treatment that we're doing, So I got chuckles. That was my second bad joke. So this looked at, in mantle cell lymphoma, the combination of ibrutinib with venetoclax. So as I mentioned before, the standard of care as second-line therapy for mantle cell lymphoma are Bruton tyrosine kinase inhibitors, and ibrutinib is a first-generation Bruton tyrosine kinase inhibitor. And so this actually looked at analysis from the randomized phase 3, and so they actually took patients with high-risk disease. This is the study design, but what this study is looking at is, again, the addition of venetoclax to ibrutinib. There had been data that shows venetoclax as a single agent can have activity in mantle cell lymphoma, and also that in combination with a Bruton tyrosine kinase inhibitor. So in this patient population, we can see that in terms of progression-free survival, that there's an improvement, and this was actually double-blinded. So the investigator didn't know and the patient didn't know. So it's instead of getting a venetoclax, they got placebo in this situation, and you can see there's an improvement. And so there's a big debate. Do you give venetoclax plus a monoclonal antibody in this patient population, or do you give a Bruton tyrosine kinase inhibitor? And this data would kind of saying, well, why don't we put them together? And it actually shows an improvement in progression-free survival. Now, another study that I thought was really interesting was the addition of venetoclax to standard R-CHOP in diffuse large B-cell lymphoma that are double expressors. Now, there's known as double hit and double expressors. And when we talk about double expressor and double hit, it's the BCL2 and the MYC by immunohistochemistry. But a double hit, you actually have to show the mutation by FISH. So this is only done by immunohistochemistry. And so double hits are really, really bad. Double expressors are bad in terms of when you look at them in terms of diffuse large B-cell lymphoma. So what they did was a randomized study comparing this, and surprisingly, this is one of the few venetoclax studies that does not show any benefit. Matter of fact, the overall response rate was nearly identical. Now, you can argue with me about this complete response rate, but it did not reach statistical significance. And when they looked at progression-free survival, identical, and they looked at overall survival, it actually favored R-CHOP, and the toxicities, particularly cytopenias, was markedly higher with venetoclax. And they go, and from this, they said they do not recommend the use of venetoclax with R-CHOP in double expressing diffuse large B-cell lymphoma. Another disease for which is the bane of a lymphoma doctor's life is Richter's transformation. So I do I used to do a lot of transplants for Richter's transformations with the introduction of Bruton tyrosine kinase inhibitors. I rarely see patients for that way, but there's still a proportion of patients who do develop Richter's transformation, and the median survival for that group of patients is 6 months. And as a matter of fact, they're very refractory to standard chemotherapy. We try to get them to transplant, but only about 20% do. So they actually looked at the use of CAR T cells. As a matter of fact, what's really interesting is when the original use of CAR T cells in Richter's transformation, it stunk. As a matter of fact, companies started shutting down their trials because they weren't getting good results and they didn't want to, they would have bad results. But there had been a signal that maybe liso-cel, lisocabtagene maraleucel, which is a CD19 CAR, could have activity in Richter's transformation. And so they used the international registry, which is known as the CIBMTR, and they identified 30 patients who had Richter's transformation and got liso-cel CAR T cells for their treatment. And these were the results. They showed that the overall response rate is 76%, but then what's more important is the complete response rates, 66% complete response rates. And if you look at this page, you can see, look at the duration of response. Among responding patients, 3/4 of patients maintain that response. So this is really encouraging. And again, for a relatively rare situation, but for your patients, there's not a heck of a lot of options. So this really speaks a lot in terms of what CAR T cells. Now another thing, if you look at all the CAR T cell studies, one of the primary exclusion criteria is CNS involvement. And matter of fact, the concern is CAR T cells won't necessarily get in there, and that if they do get in there, they're going to cause a heck of a lot of problems in terms of neurologic toxicities. Yet people anecdotally had noted that there were responses by CAR T cells. As a matter of fact, when they did spinal fluid analysis, they could actually find the CAR T cells floating around in the spinal fluid. So Karen Jacobson at Dana-Farber, she led us a pilot study of looking at another CD19 CAR, axicabtagene cytoleucel or axi-cel, in patients who had not only primary central nervous system lymphoma, but secondary. So this is, primary is almost exclusive, it is by definition exclusive to the brain, but there are patients who develop brain metastases who have systemic diffuse large B-cell lymphoma. And so in this study, these were 30 patients, and I'm showing you the swimmer's plot here, is that you can see that there was a high overall response rate. 94% of these patients responded, but what's more important is 67% of these patients achieved complete remissions, and many of these are ongoing. What you're looking here is these 5 arrows are patients who receive radiation therapy, palliative radiation therapy to the brain before they receive their CAR T cells. And what's really cool, and I always apologize that I'm pointing to this side, you guys are just as important over there, is that a picture's worth 1,000 words. So this is one of the patients that you can see. You can see these great big lesions, particularly here. And at 6 months, there's complete resolution. So this is a big boon for us because we take all these patients to transplant, half of them relapse, and what do we do afterwards? Because the prognosis is dismal after failing an autologous stem cell transplant. So this is a new option for these patients. Now I'm going to turn to chronic lymphocytic leukemia, small lymphocytic lymphoma. How am I doing? I'm still okay. So this was another standard of care in treatment of chronic lymphocytic leukemia. This is the most common leukemia that we see in clinical practice. I mean, it's inevitable. And matter of fact, the incidence is there's 200,000 people walking around the United States. Half of them don't even know, or that we documented. There's another half that don't even know they have chronic lymphocytic leukemia. So this is a big thing. And again, the standard of care for the past 10 years has been Bruton tyrosine kinase inhibitors. But more recently, people have introduced venetoclax in combination with a monoclonal antibody. And so people have been very interested. As a matter of fact, there's a big debate in the CLL community because there's people who say you use Bruton tyrosine kinase inhibitors, and other people go, you know, patients don't want to be on a drug for the rest of their life that has a lot of toxicities. So people have been, well, what if we put them together? It's very similar to mantle cell lymphoma. So this is This is looking at a combination of a first-generation Bruton tyrosine kinase inhibitor, ibrutinib, in combination with venetoclax. And this is known as the Captivate study. And so now we have 5-year long-term follow-up data that was presented at ASCO. And this is very interesting data because they looked at these patients with and without TP53 or 17p deletion. That is the worst prognostic group relative to chronic lymphocytic leukemia. Oops. And what is important here is that they would have fixed duration of therapy. They go 18 months, and then they could stop if they achieved a deep remission. And then they look to see whether or not, if you stopped, you could come back and treat again, either with venetoclax or with ibrutinib. And they actually saw, you can see that the progression-free survival and here for these patients, and again, for those not familiar with chronic lymphocytic leukemia, these are actually excellent results in terms of progression-free survival. The overall survival is close to 90%, but so the majority of patients, 50% of the patients maintain their response after stopping, and when they went back to treat them with either ibrutinib, venetoclax, they had over a 70% response with each agent individually. So it gives us some degree of comfort when we come back because with the Bruton tyrosine kinase inhibitors, just keeping them on, they have excellent progression-free survival, but they have to stay on the drug forever. And patients don't like it, and there's associated toxicities, hypertension, bleeding, and secondary malignancies. So this permits a break and a comfort to us that if we do this, we can come back and successfully treat these patients. So I'm going to turn to myelodysplastic syndrome. And so this is a preliminary paper on the use of oral azacitidine. So this is in low and intermediate risk MDS. So the treatment of choice in this situation when you do need to treat is usually a hypomethylating agent. And for those, for our nursing colleagues, our physicians, you know that trying to set up getting 7 days or 5 days of IV azacitidine or decitabine is tough. And oral azacitidine had been investigated a few years ago and actually showed some benefit in this group. However, it was associated with early deaths, primarily from infection because of severe cytopenias. So this study actually redid the study, but and the original study had a 21 out of 28 day dosing for oral azacitidine. This study had a 14-day out of 28 days and looked at 2 lower doses of 200 and 300. So the original study was 300, 21 out of 28. This looked at 200 and 300, 14 out of 28 days. And what they show, and again, it's semi-underwhelming. This is looking at hematologic improvement, and where they saw the biggest improvement is in the erythroid series, so in terms of red blood cells. And there were some improvement, but stable disease was seen in the majority of patients, and toxicities was slightly higher with the 300 milligram dose. And so, but was not significant, but when you did look at toxicities, but they didn't make any clear statements other than this was feasible, there was a signal of improvement, and needs to be further investigated. So I think this, if this does bear out, it'd be really nice to be able to tell our patients, here's your pills, go home, we're going to see you and get your CBCs once a week, rather than having them come spend a week or 5 days with us in the clinic relative to their myelodysplastic syndrome. And then finally, I'm going to close out, which I didn't get excited about until I read it. So as a person who does transplants for myelofibrosis, I mean, one of our biggest things is patients with huge spleens. And matter of fact, I always think it's kind of funny that the bar for myelofibrosis, can you shrink a spleen? And actually the drug that ruxolitinib got approved is because it shrunk a spleen by 35%. And I go, wow, I'm not sure that's a big deal, but the FDA thought it was. And so this study was the Manifest study, which actually looked at a BET inhibitor, pelabresib. and it shows some activity in myelofibrosis. They go, what if we combine this with ruxolitinib? What will happen? And so they did a randomized study. And so in this study, patients either got pelabresib, and it's an oral drug, day 1 through 14, along with ruxolitinib, or they got oral placebo plus ruxolitinib. And again, the primary endpoint was this spleen change of 35%. And what they showed, so here is what was seen with just placebo with ruxolitinib, and there was about 35% of patients had a 35% reduction. And that's actually what was seen with the original ruxolitinib study, because I always think it's important, is this data consistent? And these were the results with the addition of pelabresib. And you can actually see it's a doubling in terms of spleen size. As a matter of fact, the reduction in spleen size is far beyond 35%. It is actually about 50%. And on top of that, they actually had a hint that it improved hematologic parameters, particularly red blood cells. So this actually should become the new standard of care once it gets approved. So I think for our myelofibrosis patients, this is actually pretty good. So that's my time. I did 32 minutes, so not bad for, and hopefully you'll learn something today about, it will help your clinical practice. So I'm glad to take questions with the panel.
Thank you, everyone. And thank you for talking about the whole hematology in 32 minutes, the malignant hematology. We'll take the questions from the audience first. All right, while people are gathering their questions together, I think I can start. So you touched upon a little bit about how to sequence when we have effective therapies in relapsed or refractory population. So you talk about myeloma, then you have 3, and then you talk about lymphoma. You have the same thing, BiTEs and CAR-Ts. In your practice, how are you really kind of going through this complex answer for individual patient?
Yeah, it's a fantastic question. And I really do think that the biology of the diseases and the therapies that are being used are different. So the data that I showed was for BCMA therapy. So BCMA stands for B-cell maturation antigen, which is found on 99.9% of myeloma cells. And so all of these therapies are BCMA directed. And I was agnostic towards this, but I find this data compelling. I want to see more because it is a retrospective analysis, and who knows how they chose and everything else. So in comparison, when we look at like I showed glofitamab data. So glofitamab is targeting CD20, yet most CAR T cells target CD19. So there it becomes, again, 2 different modalities and how that affect, because we do know that in patients who have prior CD19 therapy, that it does affect the outcomes of patients who receive CAR T cells. And so if you have an anti-CD19 therapy, how do you sequence that? And I don't know that. There is some suggestion that it makes no difference whatsoever. So in terms of, that's a target. But the other question becomes, let's say you use a bispecific, a CD20 bispecific like glofitamab. Will that affect, because you're trying to bring the T cell to the tumor. And will that exhaust your T cell population? Will you get a population of T cells that are actually worn out? Like when you bring them to get CAR T cell therapy, you do the leukapheresis and you look at their T cell population and they're worn out. They go, how are we going to do? You know, and there actually is data to show that. However, so far, there doesn't appear to be any significant effect upon efficacy of CAR T cells in that situation, and vice versa, if you use CAR T cells and then use glofitamab. So, or one of the other CD20 specific T cell engagers. So So I think it depends upon the disease, and it depends upon the target, and so that it may be a combination of the two. So for myeloma, I am much more, be more cautious. I'll tell people not to do this, and I actually think this data shows, it was really interesting that they did it. The responses when they used teclistamab frontline was not that great. It was less than a 30% complete response rate. So, and yet, are you gonna compromise a patient when they can get, the CAR T-cell data keeps getting better and better in myeloma. I think you're gonna see some really cool data at ASH. So I don't wanna compromise these great results in my myeloma patients. In the lymphoma, I'm gonna wait for data.
Yeah.
And so I know I sidestepped that. I kind of declared it in myeloma. In lymphoma, I'm going to wait. And I do think it's going to be a difference between if it's mantle cell, diffuse large B cell, and follicular lymphoma. And so we need to delineate those as well.
With all the options we have for CLL, at what point should the community refer for CAR T?
I think the question is so there is CAR T cells for CLL. That's what you asked, not? Yeah. I get I just want about mantle cell. I'll just be bluntly honest that the results with CAR T cells in CLL is disappointing at this point in time. And so that the overall response rate's about 40 to 45%, about half of those, or 20 to 25% are complete remissions. So, I think that's a reflection of the biology of the disease, because actually T cell function in chronic lymphocytic leukemia, which is a B cell disorder, the T cells stink. People don't realize, and matter of fact, if I give this lecture on CLL all the time, and the only thing I want them to remember is that infection is the #1 cause of death in CLL. And they die of viral infections. And people don't realize the #1 COVID cancer-related population, that patients with cancer, the highest percentage was in CLL. Beats every other cancer, even acute leukemia. And so, so that may reflect why the outcomes are not as good as compared to some of the other. I mean, even we're seeing the central nervous system lymphoma patients look great, and yet CLL did. So I agree with you that there are so many good options, and again, but what's going to happen is when you start using a combination of venetoclax and a Bruton tyrosine kinase inhibitor, because that was just with the first generation. The efficacy of the Bruton tyrosine kinase inhibitors are equal, it's just the toxicities. But when you start using a Bruton tyrosine kinase inhibitor and venetoclax, what do you do then? And then we're going to even have a tougher patient population. But I would say that's what you need to do. They're going to need to see venetoclax and a Bruton tyrosine kinase inhibitor before I think they should be referred for CAR T. So you're hearing that from a person who does CAR T cells.
Well, this is a loaded question, but I get it all the time from everybody in a way. And and it's a good problem because we do have a lot of product within a group, meaning you talk about CAR T cells, there are 4 approved products that is out there in commercial setting. Many are coming up in the trials. There's autologous, there's allogeneic CAR T cells. When you talk about bispecifics, there are at least 2 approved for diffuse large B-cell lymphoma. A couple of them are approved for follicular. Some are going to get approved for mantle cell very soon. So when it comes to individual products, how do you pick? Meaning, where do I said it's a loaded question.
Yeah, no, it's really, really fair. And I get asked the same question all the time. So when I'm looking, which disease are we talking?
Well, let's talk about lymphoma instead. Let's talk about 4 products out there in diffuse large B-cell lymphoma.
What's that?
Large cell.
Okay, so large cell lymphoma. In patients who are younger and more fit, our group leans towards axi-cell almost all the time. However, I'm part of what is referred to as the CAR T-cell Consortium, which is a group of institutions which are asking the same question. And all these institutions be part of this consortium have to be agnostic to and have to have availability of the 3 CAR T-cell products for diffuse large B-cell lymphoma, which is Tezacel, Lysacel, and Axicel, and they all have different characteristics. And we know we have inherent biases, but and again, many of us the same way. In an older patient who has comorbidities, we lean now more towards Lysacel. And in the younger fit patients and more aggressive disease, Axicel. But when we looked at the Lysacel in the real world situation, and this is going to be, the abstracts haven't come out. I think I'm going to get in trouble. The results with Lysacel are really good. We're seeing complete remission rates approaching 60% that are durable. So if you have a product that's as efficacious and has less toxicity, which it does, because it is the difference between Lysacel and Axicel is a CD28 co-stimulatory domain, and Lysacel is a 4-1BB, and 4-1BB products have less cytokine release syndrome and less neurologic toxicities. And so so if you have equal efficacy and less toxicity, why aren't I always say that's going to be the winner chicken dinner. So that's where we're changing our thought process on that.
There's another abstract at ASH, which I can't release the data, but prophylactic dex for Axicel, do you think that's going to balance them? Or?
Yes, so I think it's the Zuma whatever study did show that giving dexamethasone ahead of time does mitigate that, but still the toxicity rates are pretty high, and if you don't have to give dex, it's a better deal.
All right, thank you very much, and I did get my signal to close down the session. Thank you very much for everybody being here.
Thank you again for a great session.